Good evening and good morning, all of you. We are on our fifth Zoom meeting as part of the Learning Basic Arthroscopy program. As you know, our motto is to cover one small topic at a time for beginners and seniors. Here we have Mr. Bobby Anand. Mr. Bobby Anand is a consultant trauma and orthopedic surgeon at Southwest London Elective Orthopedic Center, and he is also director of Surrey Knee Clinic. He is member of National Orthopedic Alliance and lead member for Sports Knee Group. He is also SICOT Sports Knee Committee member. We also have Dr. Srinivas. He is orthopedic surgeon and knee arthroscopy surgeons from Vijayawada, India, and myself, Dr. Saseendar, shoulder and knee arthroscopy surgeon. We also have an invited guest delegate, Dr. Tejas, as part of the quiz program that we conducted in Learning Basic Arthroscopy. Okay, so we are live now. Mr. Bobby, welcome and thanks for accepting our invitation to deliver your knowledge. You can go ahead. Thank you.
Thank you. Thank you very much for the kind invitation. I will just get my screen share going.
Yeah.
I hope everyone is well during these challenging times. Okay, and thank you very much for the kind introduction. So I've been asked today to talk about femoral fixation options in ACL surgery. Thank you for the kind introduction. As has been pointed out, I'm a knee surgeon. I specialize in I have a solely knee practice for the last 7 years. I've been very lucky to be elected onto various committees and both nationally and locally. So an outline of the discussions today. I was going to discuss some common femoral fixation options. We were going to look at the evidence around this. We're not going to go into too much detail because we've got 15-20 minutes, but if there's any questions afterwards, we can address those. We'll discuss a few simple cases, and I'll express my views on femoral fixation, and then hopefully open up to everyone. Any questions on anything knee related, I'm happy to take. So the fixation device really functions to hold the reconstruction in place during early rehabilitation. So our aim is we want minimal slippage and disruption of the graft from the fixation device. And the device is probably important for 3 to 6 months post-surgery. If we look at BTB, you start getting bone healing at around 6 weeks. If you look at soft tissue autografts, aperture healing starts taking place around 8 to 12 weeks, and allografts take a lot longer. So when considering any device, we look at the biomechanical factors that we need to account for. And strength is a very obvious one, the ultimate load to failure. Noyles in the 80s and 90s published some work on this, and he estimated that an ACL strength, the load going through an ACL for activities of daily living is around 450 newtons. So that's an important figure to have in the back of your mind when we go through the slides and to see the devices and how they cope with that. And then from the mechanics point of view, stiffness and slippage are very important. From a surgeon's point of view, what that really means is the device going to let my graft loosen? And that's what we need to know. So types of femoral fixation, there are many types, but if you break it down into 2 main groups, you have aperture fixation, which in most people's practice, this will be an interference screw, either inside out or outside in fixation. There are still surgeons who use a pure bone block with no fixation, but that's not particularly mainstream now. And then you have suspensory fixation. And so you have cortical suspension, such as your tightrope. And then you have cancellous fixation types, such as transfix or rigid fix pins. This Scandinavian ACL registries are really good sources for data, particularly looking at historical trends. I'm very cautious about interpreting registry data in general for outcomes, but for data like this, it's quite useful to look at them. And if we have a look, you can see that in Sweden in 2015, 27% of femoral fixations were with a metal screw. And you can see in 2018, it's dropped down to 9%. So a very clear trend in drop in metal screw usage. At the same time, there's been a big growth in use of endo button, a fixed loop suspension device, from 10% to 24%, and a really significant growth in the use of tightrope, which is an adjustable loop. So from non-existent to about 58% of their practice now. At the same time, the transfix type pins have really reduced in usage. So they formed over 50% of femoral fixations in 2005, and now barely anything. So a really clear trend in change in trend there you can observe. So if we look at interference screws, there are a number of advantages. They're traditionally regarded as the gold standard. It's a tried and tested technique, commonly used for BTB. So for all my BTBs, I always use screws both ends. But for soft tissue grafts, we're seeing that the usage is dropping. There's good published data, and it shows that it works. You get reduced graft tunnel motion with a screw at the femoral side. This has been linked to reduced tunnel widening, but there again, there's conflicting data on this in the literature. But screws do have disadvantages, particularly in the femur. It's very easy to get screw divergence, and we don't know the effect on mechanical hold and load. There are a couple of papers I've reviewed, again from early 2000s, that show not a massive effect if you do get some screw divergence up to about 15 degrees. But I think it's a little bit more common than we appreciate, and I don't think we fully know how it loosens the femoral fixation. And you can get graft or suture laceration, and anyone who's put screws in the femur will know this. You have to be very careful and develop your technique to try and minimize that. I occasionally put screws in, and this is the bit I really dislike when you see it rubbing on the graft. It's not a nice feeling. Hardware removal, again, sometimes can be an issue in the revision setting. Then if we look at cross-pin type devices, as I've shown, the usage in Europe has significantly dropped, and it's the same in the UK. Yeah. There are advantages of the crosspin. They still have some good data supporting them in terms of strength of fixation. And if anything, they're possibly the strongest type of fixation for a soft tissue graft. And there is some registry data that shows lower revision rates with it. However, there are lots of disadvantages with the crosspin devices. They definitely have a higher complication rate than other devices. There's lots of papers published on this over the last 10 years. It involves more steps. Whenever there's more steps in an operation, more things can go wrong. They're not designed, in my view, for anatomical type ACL reconstructions. They're better designed for the transtibial. You have a safer zone to put them in. Using non-metal ones, there is a rate of pin breakage, which has been an issue. Pin site pain has been an issue. ITB issues are quite common with this. And there is a risk to neurovascular structures. You see these case reports come out now and again with the complications of these. And again, in inexperienced hands, it can be a challenge. Hardware removal, this is the most common time I come across the transfix when I'm doing a revision, and they're not particularly enjoyable to remove. So then we get on to suspension device fixation. And really the big debate in the literature is all about fixed versus adjustable loop devices. If you look at, there's lots of papers on this, and there's so much conflict, but in general, they all function pretty well. This paper by Patrick Smith's team shows that all of the ultimate failure loads are above 500, which was that threshold you're looking at early on. So whichever system you're using is good. And they showed that actually the tightrope had the best ultimate failure load. But then there are other papers, and this paper published in the knee in 2014 showed that the fixed loop had superior mechanical strength compared to the adjustable loop. So when you have good quality papers telling us to go in different directions, it's really hard to fully trust the mechanical data that's coming out. And it's very similar with stiffness or slippage data. I think most devices, if you look at the literature, will slip about 2 to 4 millimeters, all suspension devices. And actually, there's some data with screws that show they slip a similar amount, possibly more. This paper led by Christopher Turlow showed that the adjustable loop had the lowest slippage rate compared to screw and fixed loop devices. But again, there's been a conflicting paper by Barrow in American Journal of Sports Medicine in 2014, which they were doing cyclic testing with cadavers, I think it was, and they showed a really clear increased slippage with the adjustable loop. So again, we don't know, these are all good papers, which is correct, we just don't know. But does it really matter to us? We're surgeons and these are mechanical tests. What we need to know is how these translate to our clinical outcomes. And again, when you look at the literature, it's pretty consistent that we're safe with whichever direction we choose to go. So these two papers, the first paper in American Journal of Sports Medicine in 2018, looked at around 270, 280 patients, and they looked at laxity scores 2 years post-surgery between an adjustable loop and a screw fixation in the femur, and they found no clinical difference in outcomes. They found no difference in knee laxity scores. And the paper by Meyer in a very recent paper in Kester looked at screw versus adjustable loop, and they found, again, no clinical difference, and they reported less tunnel widening when using the adjustable loop in the tibia. So they're talking about an all-inside type technique there. So results generally are good. I mean, these two papers, again, looked at around 70, 80 patients, comparing fixed loop versus adjustable loop, and they found no difference at all in outcome. The second paper at the bottom is a paper from India, and that's why I put it in. It was quite a nice paper recently published from, I think, Mumbai. So generally, the results are favorable. The most recent systematic review looking at the papers overall published in Arthroscopy, and they looked at about 25 studies, I think. And their conclusion was based on that, yes, there may be biomechanical advantages of using fixed loop over adjustable loop, but that wasn't particularly clear. And there's conflicts in that data, as we've seen. But clinically, really, there was no difference at all in clinical outcomes or graft re-rupture rates. So if we look at suspension devices, fixed loop, really, what are the advantages? Possibly you get a lower slippage risk. Conflicting data, but possibly. But they've got widely proven good clinical outcomes. So you're safe if you're using an adjustable loop. If you're using a fixed loop device, you're pretty safe. There are disadvantages. They are more difficult compared to the adjustable loop to play around with graft length, to adjust your tunnel lengths, and to adjust your thickness of your soft tissue grafts. And I had a question coming in earlier that was about that. So I think the fixed loop creates, you can do it, it's just a bit more tricky. One of the bigger disadvantages for me is that you can't do a final tensioning with a fixed loop once the tibia is fixed. And as with anything, you need experience with the device you use. You need to ensure you get good tactile feedback and you know what you're doing. Otherwise, you'll end up with a situation like this on this image on the other side. Adjustable loop devices, and the most widely used is obviously the tightrope. These, again, widely used, good clinical proven outcomes. Some of the advantages I've mentioned on the other side are that you can tighten the graft at the end of the procedure and you can visualize this. And I quite like that you can physically see the graft tightening up. It adds flexibility for the surgeon for your graft diameter and your tunnel lengths drilled. So you've got a little bit more room to play with big legs, small petite legs. It gives you a bit more play with your tunnels. If in the back of your mind, you know your femoral tunnel is going to be, for example, in a small patient, my tunnels can sometimes be down to 32, 30, 34. It gives me a bit of jiggle room. And also with a big patient, you know, my tunnels might go up to about 46 millimeters. So again, you can plan a bit more carefully. But there are disadvantages as well. The slippage risk has been described. Again, the tactile feedback is very different, and you need experience in using it so you don't make a mess of things. There were just two cases I wanted to discuss, and they relate to fixation, but they also relate to my evolution and thinking of how I do things. So this was a 22-year-old, quite high-level netball player, and she was treated by a decent surgeon, but he did something very strange. Because she was a professional, he decided, the panel probably know what's been done here, but he decided to put in a synthetic ligament using the LARS for a primary ACL in an elite athlete. And she was very keen to get back to netball. You know, she wanted to get back in 6 months. And so he promised her this, which is a very dangerous thing to do. And this was the reconstruction. She came to see me around about 9 months to 1 year after her primary indexed operation. And at that point, she was still unable to run. She had this flexion deformity that you can see on that. That's as straight as she could get her leg. And she was finding day-to-day activity difficult, never mind getting back to any serious sport. The MRI image here just shows the where the tunnel was, which is, you can see it's quite a very proximal and very anteriorly positioned tunnel with a very rigid type graft. So these were just some images of this knee. Fixation was, again, an outside in. So it was, in my view, it was probably not the best graft choice for a high demand athlete. The tunnels were a problem, and it was a 20-degree extension deficit, and the ACL was obviously intact. So I decided to revise this, take out the intact ACL. And this was a time where, I think I did this 6-7 years ago, where I exclusively used suspensory devices for my revisions. And for this particular revision, it was brilliant because I didn't have to worry about removing the metalwork. I didn't have to worry about my screw hitting the other screw. Didn't have to go and explore this area at all. And so it was a very easy, straightforward revision. In those days, I used plastic screws, which I don't now. I only use metal. That's my only thing I don't like on this X-ray. But it was really easy easy revision. The tunnel positions were good, and she got back to playing netball in about 12 months or so. My changes really come with the revisions in terms of, I think I augment my fixations a bit more. And this was a case, again, not particularly recent, probably about 4 years ago, where I had a 19-year-old, again, he was a professional boxer. He ruptured his primary ACL playing football. He had a primary ACL with a hamstring reconstruction. And that the ACL was intact. As you can see from the X-rays, he had a transtibial type technique. And transtibial techniques work. That they've worked they work for many people. Just for some patients, particularly high demand patients, they're not enough. And so this man was very stable in the AP plane. He could do everything day to day, but he was unable to return to boxing. He was right hand dominant. The left was his lead leg. Every time he loaded his left knee and he was going to throw a punch, his left knee felt wobbly. It felt like it was going to give way on him, and he couldn't get back. So again, looking at the tunnels, for me, they were not in an ideal position. Again, very proximal on the femur. So again, this was, from my point of view, a relatively straightforward single stage, because the femur was not going to be a problem for me. The tibia was within acceptable limits. I think I would prefer it to be slightly more anterior than it was there, but it was within acceptable limits, and you can do little tricks to adjust that if you need to. And so this would be my more common scenario now with femoral fixation. So I would do a double fixation, particularly for a high demand person. I like the suspensory fixation, but I always augment it with a usually 7x25 femoral screw, just to reduce that motion at the femoral site in a revision situation. And this patient, I chose to do a hamstring as opposed to patella tendon, because it's his lead leg, and he really overloads the tendon. In boxing, you overload your tendon a lot on the left leg when you're leading. I didn't want him to run into problems with anterior pain when he's boxing. And so that was the decision, and he had double fixation. And the nice thing about using the screws, obviously, you can see what you've done, and there's nowhere to hide. And again, you can see that the tunnel positions were different, and he did pretty well. I think fixation has become more important as patients' demands have grown, because even 10, 15 years ago, patients would have an ACL and be put into a brace. How do I turn the sound off? Be put into a brace and be given slow rehab. My patients that I work with in London and Surrey, they will not accept that. They want to get going quickly. I mean, the picture on the left, this was a surgical colleague. She's also a very good skier. She's a general surgeon, had a ski injury. I mean, this is her post, this is what she's doing to the knee, sending me videos at 6 weeks post-surgery, really testing her knee, putting phenomenal loads through it. And you need a device that can cope with that sort of person who's going to really intervene early. But it's not just the young. I mean, she's about 30. This is a lady who's 60 on the other side. And I haven't put her running videos up, but she had a foreligament injury. So I did a PCL, ACL, MCL posterolateral corner on her. Again, in the past, she was an elite skier. She's about 61 now. When I operated on her, she was, I think, 59. And the demands that this lady put on her knee in the first 6 to 8 weeks post-surgery were phenomenal. And you need to be able to, she didn't go to a plaster. She was given a knee brace for 4 weeks, and then she got going and started doing, she worked with about 10 different personal trainers for different things. So the demands that people put on are really high, and we need to be able to be confident in our early fixation. So really, my conclusion from the literature and from experience is that most devices work well. You've got to know your technique, pick the device that suits you, and that suits the graft that you're using. And I use different grafts for different patients. We customize the graft for the patient. So you sometimes have to customize your fixation. Use what you're used to. Make sure you understand the problems with that device and the advantages of that device to work around it. I've been a fixed loop user for about 6 years. I've now I'm moving mainly to adjustable loop. I've not had any problems with my fixed loop because I know it very well, and I've got good outcomes with it. But I like the option of an adjustable loop, particularly in some of my high demand patients, because if I get a bad hamstring graft, I can do things to bulk it up. I like the feeling of tightening it towards the end of the operation. It gives me that confidence that it's a nice fixation. But you need to be flexible, I think, in general, and be able to use a range of devices, because if one thing is not working, you need a plan B. So really, the conclusions are femur fixation choice is important, but to be honest, ACL surgery, femur fixation is a simpler decision. There are other factors that are more important. It's really important to get your basics right with ACL, get a good reproducible technique. If you've got that, you'll get good reproducible results. So it's important to keep things simple. I mean, I think the key with ACL surgery is understanding your high-risk ACL patients. We will all have a group of ACLs that no matter what we do are going to do well, low demand patients. It's the high-risk ones that you need to be able to identify, the hyperextenders, the varus, the young kids who are going to go back to high sport. These are at risk of failure, and you've got to plan how you're going to cope with that. Thank you.
Thank you very much, Dr. Bobby. It was a very short and sweet presentation with a lot of evidence and covering all the options that are available at present for the fixation on the femoral side. As you said, it is very important to know the biomechanical differences between the fixation options, but also on the other side, we have to understand that all the biomechanical evidence doesn't equate to clinical outcomes.
Absolutely.
We need to also know that the clinical outcomes are, yes, more important, considering also the biomechanical findings from evidence. There are a couple of questions that I would like to ask. What is your opinion about the bungee cord effect with respect to suspensory fixation? Have you, is there a clinical way in which you can identify it, and what are the incidents and what is the possibility of failure because of that?
I think so what you're talking about is up and down movement in your tunnel,
Yes.
essentially.
Yes.
So I think you will get it, particularly if you do an anatomical ACL reconstruction. So we know that, you know, some of the older ACLs that were more isometric than what perhaps, you know, a lot of us do now, you wouldn't get that movement. Whereas with a you know, true anatomical, I think you do get more of that up and down movement. And so the question is, how do you need to mitigate it? Is it a problem? So one of the things I do is I do go a lot slower. If I do an isolated suspensory fixation, the first 6 weeks, I prefer my patients not to get on an exercise bike and do too much cyclic loading. I just want things to settle down, give it a bit of time. Now, my personal observation is that's what I prefer to do. Some patients don't listen and go and do whatever they want in 2 weeks, but I still don't get a failure in that group. So yeah, I probably do 150 ACL reconstructions a year, and looking at the failure group, it doesn't really match up with that. So it's something I worry about in terms of your question, but it's not something that seems to correlate out with a clinical impact. But as a caution, I go a little bit slower in the first 6 weeks to reduce that. With the revision scenario, I tend to do a double fixation.
Okay. And regarding the fixation with suspensory fixation on the femoral side, do you have an intraoperative? What method do you use to make sure that the button is not in the soft tissue? Do you use a C-arm, or do you regularly use a C-arm? And what determined that you may be using a C-arm intraoperatively to make sure the button is not in the soft tissue?
I have to say I never use a C-arm. Okay. And if I have any concern that the button is in the soft tissue, I put a screw up. So that's the way I mitigate it. So we have two knee surgeons in one of our units, and we both have a very different approach. Getting a C-arm in, I don't know how easy it is in your unit, but my unit, firstly, I don't like the radiation, and I don't like to wear leads. And secondly, in the middle of an operation, if you need it, it could take you half an hour. And you know, an ACL should take you 20, 25 minutes. So you don't really want that delay. So what I do, and it's very, I would say 1 in 50 ACLs, I have a question mark about my suspensory fixation. In that situation, I put a screw up, and that problem is dealt with. I don't have to overthink it. My colleague, on the other hand, will get a C-arm in, and if the button is not sitting right, then he will open up, put an extendo button in, or do if he thinks he's blown out. I don't know which is the right thing to do. I personally feel that I've got other options available to me, and so I will just use that. And actually, in those situations that I've had, most of the time when you look back, actually the endo button has worked and it is sitting quite well. It's quite interesting. You look back at those cases. Okay, you definitely have 1 or 2 where it's sitting off 3 or 4 millimeters. So it's probably the right thing to do. But yeah, so my approach is I will just, if I have a doubt about the suspensory fixation, I don't ignore it. I just put a double fixation in, and that way I get around that problem.
Yep. I think it's a very good point that in order to avoid the delay in surgery and possible risk of infection, it's a good point to go ahead and put a screw inside. One thing I observed in my experience, when I have a doubt, sometimes what happens, I actually propose it as a possible method, and we are still working on the outcomes of it. What I observed is when it's in the soft tissue, you can actually try to pull it and relax, pull it and relax. It sort of springs out and goes back, bounces back. When you have the bounce back, then it's definitely in the soft tissue. I mean, this is something I observed, and this I even cross-checked with C-arm for a couple of cases, and it was inside the soft tissue. I mean, just for the what do you say, the academic research part, we cross-checked with the C-arm. Otherwise, what I do when it springs in and out, I pull it out completely. I unflip the button again. I pull it out completely and go in again with the flipping. Okay. In my experience, it has worked. So possibly this could be one of the techniques. Yeah. So Dr. Srinivas, do you have anything to ask?
Yeah, that was a very good presentation. Thank you very much, Bobby. Regarding this checking the button flipping, I do adjustable loop fixation. Actually, I found one thing very useful is to put your scope through the medial portal into the tunnel, and you can see the button flip out of the bone when you do that. So that's a very useful thing. I've never had problems in the positioning of the button.
That's a good technique you can use. Yeah, I mean that is a technique I've used, but I mean I suppose my stance on that is, if I have any doubt that the button is not right, I just want to you know, I can fix that button, but I will just double it with a second fixation.
Why did you change over to metal? You said you don't prefer using bioabsorbable screws, is it?
I've never used bioabsorbable. You know, we all know the problems of Calaxo screws. The modern bioabsorbable are supposed to get around it, but I have to say, for me, I know India is a big user of bioabsorbable, because I get about 5 patients a year who fly in from India for their ACL, and they all want bioabsorbable. So I don't know why, but I have to spend a long time talking them out of it. So my impression is in India it's a big thing. But my concern with bioabsorbable is, again, a lack of control. You know, as surgeons, I'm a control freak. I like to have full control of what I'm doing. With the bioabsorbable, I don't know when it's going to absorb. I don't know what toxins it's releasing. You know, we're trusting the clever engineers who've engineered something. There's always case reports of problems with tunnel widening with it. Personally, I see one problem every 2 or 3 months with a bio screw that, you know, you just see a massive explosion. And when you've had a failure of a bio ACL, I do it as a 2-stage, because I like to clear everything out, bone graft it. So with a metal, it's, you can see what you've done. It's, everyone can see your x-rays, there's nothing hidden. And if there's a problem, you can see it and you can take it out. The other thing I like about the metal is I prefer the tapers on the threads. I think it's less damaging to the graft than using the plastic or the bio, which I think is a lot sharper, and I think it damages the graft more. So my preference has always been metal, because it gives you clear evidence of what you've done.
Is that MRI compatible?
Yeah, you can do MRI with them. It doesn't, you know, doing a revision of a metal screw, you don't get any MRI issues really. You get a little bit of artifact around it, but not massive.
So your preferred fixation on the femoral side is suspensory first?
Yes.
And then if in doubt, you use interference?
Yeah. With a BTB, I always use screws both sides.
Okay, that was my next question. Have you ever used suspensory fixation for PTB, or do you?
I have, and I went through a phase a year or two of trying it, but every time I did it, I didn't feel comfortable, so I put a screw in anyway. So that's why I just stick to screws on both sides.
Okay. Okay. So I have something to ask almost every other surgeon I meet, and I'm just trying to get the trends, understand the trend. What is the position in which you fix the tibia and the knee, in 0 or 20 or 30? And there's a lot of change that is happening now.
Yeah, I fix in extension. I fix in full extension. I don't think it makes too much difference. But the reason I fix it in extension is I feel much more comfortable that, you know, I'm not restricting anything in terms of the bend. I don't use a tensioning device. There was a couple of good papers in, I can't remember which journal it was, about 5-10 years ago I reviewed, and it looked at the amount of tension you put on your graft and the final tension you end up. And generally, I think the graft loosens to what it wants to loosen to. So I've stopped using a tensioning device, but I do fix an extension. I'm a big preserver, so I preserve everything. I don't debride anything. I don't debride the lateral wall. I don't debride any of the stump. So I do, you know, what Bertrand would call the Samba type technique. And so I preserve the stump. I think that really has a big benefit in your longer term outcomes. And so I'm not worried about losing extension. So if I really wanted to, I'd fix it in flexion. You know, if you've got your tunnels in the right place, you shouldn't really lose your range. But as a habit, I just fix it in extension.
You flex your knee. How much do you flex your knee when you're making your femoral tunnel?
How much when I do? So I do medial portal inside out, deep flexion. So the technique I use is a little bit of my own improvisation of what I do. So I use, and I wouldn't recommend anyone does this in case they break the guide wire, but I use a flexible guide wire to put up, once I've drilled my 4.5 hole, my pilot hole on the femur, I use a flexible guide wire up the femur, and that means I can extend the knee. I can watch my drill bit go up under direct vision so I don't damage the medial femoral condyle. And then once it's up, then I flex, as opposed to using a rigid wire where, if we all looked at our practices, and, I've damaged a few medial femoral condyles over the years. And that's one of the tricks I've learned is using the flexible wire, extend the knee, get your drill bit past the medial femoral condyle, and then flex it up. So I have deep flexion as much as possible when I drill up.
Which fixation do you think causes more tunnel widening?
So the answer is I don't know. If you look at the literature, on the femoral side, there are papers that show you get less tunnel widening using a screw in the femur. But on the same note, there have been some recent papers that now are saying that actually you get less tunnel widening with a suspensory device. So it's not something I worry too much about. So in terms of my revision practice, I mean, how often is tunnel widening in the femur a problem for me? And it's not very common. I mean, if I look at my revision practice, most of the revisions I end up with are the femur is somewhere I don't need to go, so it's a bad femoral position, so it's an easy femoral revision. Tibial tunnel widening I see a lot of, I see that with metal screws, I see it with bio screws, I see it with plastic screws. So I've seen it with all forms of devices, really. Interestingly, where I've never seen tibial widening is with, in our local area, we had a very well-known surgeon, very pioneering for his time. He used a lot of carbon fiber ACLs. And I've never seen tunnel widening with a carbon fiber ACL. I've revised a lot of them.
Dr. Bobby, can you just unshare your screen so that people are able to see our face?
How do I do that?
You can just go to the bottom.
At the top, I think there's a pause sharing and stop sharing.
Yeah. Okay. So actually, you were talking about stump preservation. So I have a question in relation to that. Do you find that there is a possible increased risk of cyclops if you are, I mean, yes, stump preservation is very, I mean, it has advantages with respect to especially proprioception. But do you find that the possibility of cyclops is higher if you are preserving the stump?
No, I've been doing stump preservation for 7-8 years. Before Bertrand published his paper on it, I was doing it. I mean, I was trained on that when I was out in Australia. We did it routinely. The main thing to do is you've got to get your graft in the right position. It's actually quite tricky to do it properly. So I think what I would say is when you're a beginner, please don't preserve the stump because you'll get into some problems. Maybe just preserve a little bit of the base. Because there are a few things that you can do wrong when you do stump preservation. Sometimes you can come in too far behind and you push your graft forward. And I think that can create some problems potentially with cyclops, so you've got to be careful. The other thing is sometimes you preserve and then you've got to, at the end of the case, take back, have a big vista view of the knee, check the knee in extension, hyperextension, make sure they're getting it. Because again, sometimes there's a bit of your stump that is torn off during the operation, and that can cause that cyclops. So just make sure you clear it if that happens. So my experience with stump preservation is, I've been doing it for a long time. I've got quite good at it now. But when I first started doing it, I'd have some stumps that were a bit rubbish preservation. I thought, what's the point in that? And then I would remove some of it. And you have to be very careful when you remove it as well, because you can damage your graft once it's in. So it's just about getting it. If you get your tunnel in exactly the right place, and you preserve that anterior wall of your stump, then you shouldn't get those problems. So I've seen no increase in cyclops with it.
Yeah. So the trick is having your position anatomical in the tibia and also checking an extension to make sure there is nothing blocking in the notch.
Absolutely, okay. Yeah, that's really important.
Yeah. So we have some questions from the audience. There is Dr. Raghavan who wants to ask, you were talking about double fixation, especially for the high demand athletic people. Is there any evidence regarding the double fixation in comparison to single fixation? Okay.
I don't think there is. No, I don't think there is. And partly I've done this because of my training background. So I work for some very eminent knee surgeons who treated many professional footballers, rugby players, and that was part of his practice all along. And over time, as my population demand has changed from the casual sportsman to the more elite sportsman, I worry about a failure. It's very stressful for me to think about having a failure. And so I sleep a bit better having done a double fixation. Whether there's evidence behind it or not, I know I've done everything I can to prevent that failing. So again, it's not fully evidence-based, but it's based on the experience of many eminent surgeons that I've been trained by. And so it's the dilemma of evidence versus experience-based, isn't it? We can't have a full evidence-based practice because we've seen, even from my short talk today, the evidence, you can make the evidence what you want half the time. So you've got to be very careful and use your own judgment, I think.
Yes. Okay.
When you're using interference screw fixation, how do you decide on the length of the screw and use of the reverse thread screw?
So for a femur, I always use a 7x25, and if it's a right knee, I use a reverse. That's I don't adjust the screw. It's normally enough, unless you've got a really massive, hamstring graft where you've got a 10 or something. Then I'll probably upsize it to an 8 or 9. But you don't want to crush the graft. You don't want to damage the graft. It's just to hold it to stop the wobbling, because you've done your suspensory fixation anyway.
And which suspensory do you prefer, fixed or adjustable?
As I was saying, I've used I use both, but my practice is shifting over to using the tightrope, and I do like the tightrope. I think it adds, just like you, Shri, are using it. I think it adds some nice options. I've always been anxious about change because my results have always been good, and so I've not really had any problems with the fixed loop. But I think it's just added a couple of nice things, and I've noticed that the ACLs feel a little bit tighter. I mean, my view is you shouldn't constantly change your practice. I change maximum one thing a year in my arthroplasty and soft tissue practice. So, last year I decided to change from fixed to suspension, very cautious change, and I've been happy so far.
When you're fixing on the tibial side, you said you fix in extension. Do you have any preference on rotational position of the leg?
Again, I don't think it's a big deal, but there's obviously, you try and avoid the internal rotation because that's what you're historically taught. Does it actually make a difference? I don't think it does. So yeah, I mean, I try and keep the leg in extension and in a neutral position. But I genuinely don't believe it makes any difference.
Okay. Dr. Tejas has some questions. So, Dr. Tejas?
Yes. Yes. You use the suspensory fixation for the femoral side, and some surgeons also use suspensory fixation at the tibial side, like suture disc or other devices, or in all inside ACL we use suspensory fixation of both sides.
Yeah.
So let's say if suspensory fixation, if graft length or the loosening is about 2 mm. So around 2 mm at the femoral side, 2 mm at the tip.
Sorry, can you repeat it? You just cut out.
Am I audible now?
Yes.
Better.
So with the suspensory fixation at the both sides, let's assume the loosening is around 2 mm. So 2 mm at femoral insertion, 2 mm at tibial insertion, and around 2 mm or 1 to 2 mm graft also loosens. So it's around totally 5 to 4 to 5 or 5 to 6 mm. It's very significant. So what's your take on this? To use the suspensory fixation on both
suspensory fixation in the tibia, I don't have a lot of experience with it. I don't use an all inside technique. But if you look at the literature, and I think there was a paper that I put up in the talk, I think it was by Chris Viterlo. They used an all inside technique, and they found that it was actually, they found less slippage compared to a screw. So that's the only paper that I know of that's done a comparison of screw versus suspensory fixation in the tibia, which showed that it actually functions quite well, and they found less tunnel widening with it and equivocal results. The reason that I've not really used it is I don't like the, and I have debated whether I try an all inside technique. The main reason I don't do an all inside technique is because it's very hard to preserve your stump with an all inside technique on the tibia. And for me, the preserving the stump is a big factor in my ACLs. So that's why I use a screw on the tibia. But yeah, I think there is a lot of merit in a suspensory fixation on the tibia, and I've put a lot of thought into it. But as I was saying, I don't like to make too many changes in my practice at once. But for me, preserving the stump is more important than using that. In regard to your slippage question, again, it's really difficult because, you know, as surgeons, we've got to look at clinical outcomes. A lot of this is theoretical mechanical testing in a lab. A lot of it is funded by various companies, and there's various agendas to a lot of these publications. So you have to be a bit careful with interpretation of that.
You do all inside ACLs?
My next question is, when we are all go through the learning phase, and we have some posterior cortical blowout and all these things in our learning phase. So are you advocate the suspensory fixation with the suture post like fixation of the post screw or anything whenever there is a cortical blowout? But tunnel is very good, I think, much right position. So you don't want to change the tunnel position more anteriorly or more superiorly.
I mean, I think the first thing to say is try and avoid cortical blowout. It's if you're getting cortical blowout, you're covering your AM bundle maybe a bit too much. So just you know, come and cover your PL bundle a little bit more. So try and avoid that cortical blowout, because I think, again, when you get a cortical blowout, you reduce your options. And you know, with any surgery, you want to have options. If one thing doesn't work, you need a plan B. And once you get a cortical blowout, it's a real headache. And I've had to revise ACLs that I've inherited cortical blowouts from, and I really don't enjoy doing them because you can't really graft them. If they're near being in the right position, it's a headache, and I often have to do an outside-in tunnel for those ones and compromise on my femoral position a bit. So I think the first thing to say is avoid it. Avoid a blowout, because it will create problems for that particular case. It'll create problems for a revision scenario as well. And you know, there's plenty of room. You can come more, you know, cover the PL bundle much more. If you get it, then a suspensory device is the best option in that situation. Yes, because you know, you can't use a screw. Otherwise, you'll end up with that picture I showed on the talk with the screws out of the back of the knee. So yes, suspensory is very good for rescuing you in that situation. But again, try not to do it.
So
how you avoid the femoral side or femoral tunnel more anteriorly while doing the transporter technique? We have some cases with the previously done on elsewhere, which has femoral tunnel more anteriorly, and because of this, there are many issues of that.
So I didn't hear.
Can you repeat the question?
How do you prevent the femoral tunnel more anteriorly drilling?
Okay, so I think my tip for ACL is when you're doing your ACL, I'll just put a picture up just to let me just share screen. So when you are operating, and this is a really simple thing, but always think about this. So can you see the screen? So yes. When you are doing your ACL reconstruction, these are really nice dissection. I think they're from Freddie Fu's paper. So this is your femoral condyle. This is the picture most of us have in our mind, the top picture when we are operating. Okay, and you have very a very vertical appearance of the AM bundle, and the AM bundle is what most of us, I think, are trying to reproduce. That's the picture we have in our mind. But the problem is when we are operating and doing our ACL, most of us, this is the position of the knee when we are looking at the knee. Yes. And so if you have this picture in your mind when you're operating, you are going to end up putting your, I don't know if you can see my pointer, but you're going to end up putting your ACL in the wrong place. So it's always good to have this visual picture in your mind in terms of where the footprint and everything is. And one of the advantages I find now is even when I'm training our registrars, I don't remove the stump on the femoral side, because when you look, you can always see the fibers at the back. You can always see the fibers at the front. You can always see them, and you see this area where the ACL was. You can visually see it. And so actually all you need to do is, if you're really out of, you can put it there, you can put it there, you can put it there. Try not to put it there because you'll blow out, as we've discussed. So you've got a big target. You've got a big target area. The problem I find, and I remember when I was training with certain consultants, is that one of my bosses used to clear all this area, clean it all away, scrape away everything, and then start looking and saying, oh, where shall I put my graft? And then he'd end up putting it somewhere like that. So it's all in front of you. It's not guesswork. The nature has given us the anatomy. You just got to put it through where it was. And I think part of our problem is we just don't look carefully. We're orthopods. We like to make up our own rules. So if you look carefully, it's all there, and just put it through the footprint. And even if you're a little bit, there, it's not the end of the world. But yeah, that's my view on it anyway. Hopefully that answers your question.
Yeah, that's a beautiful point. We need to look for what we actually want to look for. Sometimes it happens that, we follow the books and you start going by the steps. You clear it out, and as you said, like you may be in a fix, you may not be anatomical, and nothing can replace the nature. I think we have to look for what the subtle signs that are very useful.
Yeah, and also, clearing all this, I really don't see what it adds. It adds, anything from 2 to 10 minutes to the operation. And once you've cleared it, you don't know where it is. You just made the operation harder.
Yep.
You're going to deep flexion, it further changes, isn't it?
Yeah, absolutely. Yeah, exactly. When you get into, so you always obviously plan your position at this 90 degree, because if you have this picture in your mind, then you can visualize, look at the anatomy and plan and mark your position, get your wire in, and then obviously go into deep flexion. And then you've got to trust where you put your mark.
Okay, so that's a question from the audience. If you're going ahead with a hamstring graft for ACL reconstruction and you land up in a graft, you land up in a thinner graft. So do you have some tricks to get over it?
Yeah, unfortunately, all of us end up in that situation sometimes. And it depends how bad your graft is, really. I think often the graft matches the patient habitus, but not always. And so if you get a really small, thin graft in a very petite 40-kilo patient, it may be that a size 6.5, 7 is sufficient for them. And I'm well aware of the data on graft thickness and failure rates. But the problem is, it's very much population dependent as well. And so this general rule that's emerged that, you know, your graft must be over 8mm diameter. I mean, I'm not a big believer in it. I think, you know, in my big guys that I'm treating, absolutely, I want a 9, 10 graft. But I also treat very petite, very small individuals, you know, children. You know, I don't want an 8mm graft in a 12-year-old, 10-year-old child who's, you know, tiny. So I think you've got to be pragmatic about size versus the patient habitus. But if you've taken that into account and you've still got a rubbish graft, then, I mean, some of the tricks are, if it's a nice long graft, you can obviously triple it. You can use various techniques that Arthrex have to get a thicker graft. When I used a fixed loop device, what I used to do was I'd use a longer fixed loop. So I would standard use a 15 fixed loop, 15mm endo button or whatever brand you're using. I'd lengthen that to a 20 to give me a bit more wiggle room in the tunnel. And then I would triple over and sew the top end to that device. And so you can normally increase by about 2mm with that technique by tripling over. One of the other things I do now is if I have a thinner graft, I augment it with some form of tape, synthetic tape. And I think Patrick Smith's published on that in the US. He's shown some really interesting results of, you know, internally bracing your ACLs. So I do a similar technique, and there's a technique that I've been developing for that, which at the moment I can't talk about because we've got a little patent on it coming out. But you know, for the moment, if you wanted to use that, you could use a fiber tape to augment. And I wouldn't bother sewing it in. You can just loop it around your loop or put it through your aperture. And again, that adds a bit of early rigidity to your graft. So they're really the techniques you have. I always consent patients for hamstring harvest on the other leg. So touch wood, in 7 years, over 1,000 ACLs, I've never had to. But if you're in that problem, you can always go to the other leg. You know, if you've got a big rugby guy, you've got a small leg, always consent, take permission to borrow something from the other leg as well. So they're the ways around it. I mean, that is one of the problems with hamstring grafts. Once in a while, you get a rubbish graft, and you just got to find a solution to it.
So when you use interference screw, where do you place your screw in relation to the graft on a clock face?
So I normally put the screw in, again, because so I normally I lift my graft forward, my guide wire goes posterior, so a 6 o'clock position, and then the screw goes in that, and that just rotates it around. But you can use that to your advantage. If you feel your graft could do with a little bit of shifting left or right, you can use that screw to manipulate that as you want. So that's a little technique you can use. I mean, one of the other techniques I use if I'm not 100% happy with my tibial is if I've made a little start and I've got my guide wire in, I think, oh, 0.5 millimeter that way, I wouldn't mind going, but you don't want to take your guide wire out. You can always go over it with a small, put a clip, pull it towards your direction and drill again. So you can just shift your tibial tunnel a little bit that way. But typically, if it was nice and straightforward, I just put the screw behind the graft. Is that the same as you?
I don't use screws for the.
Oh, you're all inside.
Not all inside. I prefer variable, adjustable loop.
Okay, I have been using.
You use all inside. Sorry.
I'm sorry. I have been using hybrid with adjustable loop on the femur and interference screw on the tibia. But since the past maybe like 2 years, I'm using all inside, and I have been having good results. I haven't had any issues with it, and it gives me the option of not harvesting the graceless. So I sort of feel. I mean, I have not done studies, but I sort of feel they can return back to sports earlier.
Okay.
There's one suggestion by Dr. Pebliti the other day, isn't it? If you get a short graft, his suggestion was to use an all inside. So you can have a shorter length graft, but more layers of the graft. So You can increase the diameter. If the diameter is less, you can increase the diameter of the graft.
I mean, I suppose the concern with that is how much graft do you want in your tunnels? So, you know, this is why I sometimes get worried about, you know, I feel comfortable with a minimum of, you know, again, I don't know if this is based on evidence, but I want minimum of, you know, 15 to 20 millimeters of graft in the tunnels, in the bony tunnels. And so I think you can get yourself into a situation where you end up with very small amounts. Now, again, we just don't know whether that correlates with failure or not. But it is, you know, when you're in a compromised situation, you've got to make that decision, which process, what you're willing to compromise and what you're willing to accept. But yeah, I think the all-inside offers that advantage. I agree. I suppose if you have access to that for every case, that's fine. But if you're not usually using it, and then you have that situation, then it's obviously a bit more tricky. Yeah,
I'm too quite worried about the length of the graft that is inside the tunnel, and I sort of prefer at least 20.
Yeah.
But there is possibly 5% of my cases that land up in 15 in the tunnel.
Yeah.
But what is your opinion about the reports that say that the healing happens more in the aperture rather than in the tunnel?
I mean, it's difficult to say. I mean, again, if you read the literature, that's what is described, and you know, healing is at the aperture. You know, when you go and revise your ACLs, you look at the tunnel. It doesn't look like there's been much healing there, if I'm honest. You know, when you go and drill out a revision. So I think I agree with those reports. I think most of the healing is at the aperture. The answer is none of us know. None of us know. There's nothing out there that answers that question.
Exactly.
So I think we're all just having a compromise on what we think is right. And I suppose the guys who are very pro all inside, who are experienced with these short tunnels, short bone, and they've had good results for 3 or 4 years, they can say that with confidence. Whereas, you know, if you haven't done that, it's a big leap of faith to take, particularly if you've got good results anyway.
Yeah, I think the take-home message is we are still not sure. I mean, if it is really that it's in the aperture that it heals, and if it is for a indifferent screw fixation, you definitely want a good length of the graft inside for good fixation, at least until there is healing of the graft, remodeling and all that. With respect to suspensory fixation, such a big long length is not exactly needed if it is the aperture that it heals to, but we never know. We are still waiting for concrete evidence, so it's better to be safe than sorry.
Yeah, I mean, that's the beauty of BTB. I mean, I don't know how much BTB you guys do. Yeah, my BTB practice has really increased. I probably do 20-30% BTB now. That's partly because of the type of patients that are coming in a slightly different, higher demand. But also I feel a lot more happier with, you know, letting them go quickly. It just, the BTBs, for me, BTB is probably the best graft. Even though most of us are doing hamstring, I think BTB is the best graft.
Okay. So, Srinivas, do you have anything else?
You said you do all inside, isn't it? Do you clear
Yes.
remnants on the femoral side? Do you have any issues with the remnants blocking your tunnels?
Not exactly. I don't clear everything on the tibial side. On the femoral side, it's not much that I leave, but mostly I have a feeling we tend to have more remnant on the tibial side rather than the femoral side, though there may be some sort of fiber sticking over there, but you don't actually have a lot of remnant on the femoral side. And in the tibial side, I don't clear everything. I still can maintain some tissue over there. I haven't found any major
You don't have
issues.
problems with the remnants blocking your tunnel when you are passing the ground?
Not exactly.
What
happens is like,
on the tibial side, I found a bit of an issue actually with the remnants blocking.
Yeah, and that's one of my issues with I think it's very hard to do a good remnant preserving with that technique.
Okay, maybe one small tip could be like when you're trying to pull tibial side of the graft into the tunnel, you can like sort of do a jerky sudden pull through the tunnel rather than trying to slowly pull it through. So that will prevent the button from flipping inside the tunnel, and also possibly the remnant of the graft from blocking you when you have a sudden jerky pull on the tight flap, trying to pull the graft through the tunnel. I think that's something that possibly logically works. Okay, so do you have anything else, Dr. Srinivas, Dr. Tejas? Yeah, it was a wonderful program. I think it cleared a lot of things, not only about the fixation on the femoral side. There were a lot of basics and concepts that were covered. Yeah, I thank you very much for taking the time to come over for the learners of arthroscopy. I hope to see you more often, sometime for lectures or moderation.
Brilliant. Been lovely getting to know you all. Stay safe and hopefully speak to you all soon.
Thank you very much, Bobby.
Take care, guys.
Thank you. Excellent discussion. Thank you.